بسم الله الرحمن الرحيم. Our topic for today is examination of the abdomen. We will discuss the topic of percussion. First, we have to know percussion correctly. Second is normal percussion. Then, defining the boundaries of abdominal organs and masses. Detection of ascites and its differentiation from ovarian cyst and intestinal obstruction. And then we will identify the common causes of diffuse enlargement of the abdomen. Percussion can precede or intersperse with palpation of each quadrant. It is a useful technique for detection of the size of the liver and sometimes the spleen, evaluating gas of the abdomen versus solid or fluid-filled structure, and evaluating the presence of ascites. How to percuss correctly? Evaluating an effective percussion is an act that required consistent practice, so you can do it on yourself or on your willing colleague, as percussion will be uncomfortable for patient if it is done repeatedly. The middle finger of the left hand is placed over the abdomen or over the part of the abdomen that needed to be percussed and pressed firmly against it with slight hyperextension of the distal interpharyngeal joint. Using the middle finger of the right hand, strike over the middle phalanx of the middle finger of the left hand and vice versa if you are left-handed. The movement should be at the wrist rather than at the elbow, and the percussing finger is bent so that the terminal phalanx is at right angle and it strikes the other finger perpendicularly. As soon as the blow has been given, the striking finger is raised. So the action of this percussion is a tapping movement. During percussion, there is different notes we can hear, either resonancy, dullness, or timpani. Resonancy, it can occur in an air-filled viscous. It means hollow. Dullness over a liver or spleen. Timpani, it is a drum-like and it means gas-filled stomach. We here found the figures for the proper position of the hand to do a correct percussion. Percussion over the abdomen is a light percussion, except for detection of the upper border of the liver where heavy percussion is required. There is two common mistakes which occur during percussion, either failing to ensure that the finger of the left hand is applied flatly and firmly over the abdominal wall, and second, we do the percussion striking blow from the elbow rather than from the wrist. What is the causes of dullness on percussion? Reduction of the resonancy occur in two circumstances. Either when there is an underlying solid organs enlargement as liver or spleen, or there is a consolidation of the or collapse of the lung, or there is an underlying fluid like ascites, which can be detected by shifting dullness or pleural effusion where stony dullness is found. How we can define the boundaries of abdominal organs? Percussion can help to define the boundaries of the liver, the upper border of the liver and the lower border of the liver. For detection of the upper and lower border of the right loop of the liver, it can be mapped out accurately by percussion. And this is called liver span. Start anteriorly at the second intercostal space where the note will be resonant over the lung and work vertically downward. The normal upper border of the liver is found at the fifth intercostal space in the mid-clavicular line, just below the right nipple of the in men. The dullness extends downward to the lower border or just below the right subcostal margin. The normal liver vertical height is 12 to 15 cm at the midclavicular line, 4 to 8 cm at the midline. The normal dullness over the upper border of the liver is reduced in case of liver shrunken, as in liver cirrhosis, severe emphysema of the lung, or the presence of a large right pneumothorax. For detection of the spleen, percussion over an enlarged spleen provide a rapid confirmation of the finding detected on palpation. Dullness extends from the left lower ribs into the left hypochondrium and left lumbar region. For detection of splenic enlargement or mild splenic enlargement, we do a Kessel technique where percussion over the last intercostal space, 8th intercostal space or 9th intercostal space at the anterior axillary line. During that percussion, the patient is asked to take a strong inspiration. If percussion is resonant, there is no enlargement of the spleen, and if it is dull, there is splenomegaly. Ascites. Accumulation means accumulation of the free intraperitoneal fluid. The causes of ascites is either local or general. Local causes as chronic infection, for example tuberculosis, presence of intra-abdominal malignancy. General causes of ascites is either hepatic, cardiac, renal, or nutritional. Hepatic, as in case of liver cirrhosis, cardiac, as in case of heart failure, renal in case of nephrotic syndrome, and nutritional as in hypoproteinemia. It is unwise and unreliable to diagnose ascites unless there is a sufficient free fluid more than 2 liters in the peritoneal cavity. Otherwise, if it is less than 2 liters, it can be detected by ultrasonographic examination. For detection of ascites, there is an examination term shifting dullness. For a fluid thrill to be detected, there must be the presence of shifting dullness. How to perform shifting dullness? We first instruct the patient to lie supine in position. Place your finger in a longitudinal axis on the midline near the umbilicus and begin percussion. Resonance is usually found around the umbilicus. We start moving our finger in a longitudinal position toward the flanks and do percussion. When dullness is first detected, we fix our fingers in that position and ask the patient to roll into his left side or his opposite side. Wait a few seconds, from 10 to 30 seconds, for any peritoneal fluids to redistribute and gravitate. And if ascites is present, percussion note will shift from dullness to resonance. This shifting of the area of dullness can be confirmed by finding the left border of the dullness when the patient is still on his left side, and seeing if it shifts when the patient returns to the supine position. Repeating the original maneuver but toward the left side of the abdomen. This figure, in the A position, we noted that the patient lie in supine position. We put our right hand in a longitudinal axis near to the umbilicus. We start percussion. We found resonancy in that area, and then we moved laterally toward the right flank. And in any of that position, we found start dullness. We fix our hand in that position and asked in the figure B the patient to turn to the figure C, to turn on his left side, and then we repeat the percussion. We notice that the percussion have been changed from dullness to resonancy. Why? Because the fluid have been gravitated toward his left side, leaving the upper part of at the place of our finger resonant. How we can confirm? We either move our hand to the left side of the patient, we found it dull, or we fix our hand in that position and ask the patient to lie in the supine position, and we found the percussion turned into dull. So shifting dullness, there is a certain criteria for shifting dullness. First is there is a periumbilical tympany or resonancy, and then there is a flank dullness, and dullness usually in the dependent area, and we map the line between them. This figure have shown that dullness in the dependent area, leaving the tympany above it, and when the patient on his side, tympany started to be in the dependent position, leaving the other side resonant or tympany. In case of massive ascites, we can detect it by doing a transmitted thrill for detection of a fluid thrill. The patient again in the spine position, and one hand lied flat over the lumbar region of one side, and we get an assistant to put his hand longitudinally and firmly in the midline of the abdomen. Then we flick or tap the opposite lumbar region. A fluid thrill or wave can be felt definitely, and unmistakable impulse can be detected in the hand held free in the lumbar region. The figure showing that we do put our hand flat on one of the lumbar region, and the assistant putting his hand longitudinally in the midline firmly, and we flick or tap the other lumbar region. We can detect an impulse in the flat-handed, which can be unmistakable. The purpose of that, the assistant put his hand longitudinally and firmly, is to dampen any impulse that can be transmitted through the abdominal wall. So the most common cause of diffuse enlargement of the abdomen is ascites, large ovarian cyst, and sternal obstruction. In case of ascites, there is a periumbilical dullness, there is a periumbilical tympany, and the flank is on both sides is dull. While in a large ovarian cyst, the opposite is found. There is a periumbilical dullness, and tympany is found in the flanks. In intestinal obstruction, the abdomen is totally tympanic. Thank you.